We are just so thrilled you have taken the time out of your busy schedules to join us here today. My name is Joe Gogler. I am the director of the Bold Public Health Center of Excellence on Dementia Caregiving. And today we are very excited to convene a really esteemed panel of experts to begin our conversations around the public health considerations as well as models for cultural adaptation and dementia caregiving. So again, this is presented by the Bold Public Health Center of Excellence on Dementia Caregiving in close collaboration with Us Against Alzheimer's Center for Brain Health Equity. Again, we are very excited to be working closely with the Center for Brain Health Equity in many of our efforts at the Bold Public Health Center of Excellence on Dementia Caregiving. I wanted to begin with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values: courage, wisdom, respect, and generosity. So for this event today, we're really excited. Jason Resendez, who is on our leadership core of our Bold Public Health Center of Excellence and also directs the Center for Health Equity and Brain Health. He will be live tweeting this event. And if you'd like to keep this conversation going or to weigh in while our panel is ongoing, please feel free to use the Culture Matters and Dementia hashtag and become part of the conversation. And you also see the Public Health Center of Excellence on Dementia Caregiving. We also have a Twitter handle that we very much encourage you to connect with us and share your thoughts about what you hear today and what you learn about, and questions too. As I had mentioned, we just have put together what I think is just an absolutely fabulous panel. I'm so excited to hear and learn more about their considerable wisdom, insights, and expertise in this very crucial matter of cultural adaptation in the context of public health and dementia caregiving. Nina Darby is a trainer of the Diverse Elders Coalition. The Diverse Elders Coalition is an integral partner of the Bold Public Health Center of Excellence on Dementia Caregiving and sits on what we call our Health Equity Task Force, which is really at the center of the center leadership in order to ensure that these key issues around health equity remain central to all the work we do. Also a very close colleague, Dr. Lauren Parker, who really has taken the lead in putting both this and some of the other webinars on cultural adaptation together that you'll be hearing about, is an assistant scientist in the Johns Hopkins Bloomberg School of Public Health, is a noted expert in cultural adaptation and dementia caregiving, and basically employing and utilizing novel approaches to ensure appropriate representation in dementia care research. And again, just thrilled to have her. And then another close colleague of mine, Dr. Ishan Williams, who is an associate professor of nursing as well as the assistant dean of diversity and inclusion at the University of Virginia School of Nursing. So again, just three wonderful presenters, and thank you to them, and thank you to all in being part of this conversation. Really quickly, in terms of the Bold Public Health Center of Excellence, it's designed to support state, tribal, and local public health agencies nationwide in really helping to develop dementia caregiving focused program and initiatives. And we do that really in these three ways: by helping to improve access to evidence-based or evidence-informed programming, to facilitate connections and collaboration, and then finally to offer direct technical assistance. So if you're in the audience and you are part of a public health organization or even a service provider and would like guidance, assistance, support on key issues related to supporting caregivers, specifically unpaid caregivers, family or friends of people living with dementia, please do reach out to us vis-a-vis Twitter, vis-a-vis our website, bolddementiacaregiving.org, which will be live tomorrow, or through other ways and means that we'll share with you at the end of the talk. Again, we are more than happy to connect with you. And again, a major aspect of our mission is to engage and collaborate with others to advance the public health imperative of dementia caregiving. Again, this cultural adaptation webinar series is actually the first of three-part series. More details will be coming soon on our second webinar. It'll likely be taking place in August sometime. And again, our website is launching tomorrow, July 1st. It is a pretty easy website to remember, bolddementiacaregiving.org. And again, we'll circulate these slides to you after the presentation today, so you have this handy. And again, there you will find not only a recording of the presentation and today's slides, but then also other information about your center to engage with us and partner with us. Again, we're very excited to be partnering with all different types of public health agencies, again, to really help get information, tools, and resources out there to support unpaid family, friend, caregivers of people living with dementia. And again, follow us on Twitter to learn more as well. So thanks for joining us today. We will have an evaluation form for you to complete at the end of this presentation, but without further ado, I'd really like to get into the reason why we're here, which is this great panel. And I will turn it over to Dr. Parker to take it from here. Thanks so much, Lauren.
Yes, thanks so much, Joe, for that warm introduction. On the last day of June, which we observe as Alzheimer's and Brain Awareness Month, I'm so grateful for the opportunity to lead one of 3 conversations on cultural adaptations in dementia caregiving. Culture is essential in shaping our individual experiences and health, yet little attention has been paid to the interplay between culture and dementia caregiving. Despite the projected rise in the diversity of caregivers needed in the United States, dementia support and services are not adequately tailored to meet the cultural needs of older adults and their caregivers. In this first part of a 3-part series, Nina Darby of Diverse Elders Coalition will share with us the Caring for Those Who Care resources for providers, meeting the needs of diverse family caregivers toolkit. Following Nina's presentation, Dr. Ishan Williams will provide background and context on the unique and pivotal role that culture plays in dementia caregiving. We'll end the symposium with questions and answers. Now I would like to turn the mic over to Nina Darby. Joe, thanks so much for that introduction that you gave for Nina, but just a little bit more background about Nina. Prior to joining the Diverse Elders Coalition, she spent the last 10 years providing trauma-informed programming and training to elder community members and also court personnel and healthcare and social service providers. Through serving as the training and development manager at Boston Senior Home Care, Nina trained nurses, caseworkers, and a variety of other officials on the unique and diverse needs of elders and their family caregivers. As someone who watched her mom step into a caregiving role for her grandmother, Nina holds a deep appreciation of the rewards and challenges for family caregiving. Nina holds a master's degree in gender and peace building from the UN-mandated University for Peace in Costa Rica. Thanks so much, Nina, for joining us today.
Thank you so much, Dr. Parker, and thank you so much, everyone, for being here. My name is Nina Darby, and I'm thrilled to be representing the Diverse Elders Coalition today. Thanks so much for being here and really committing to making sure that we're being adaptive to the cultural needs of the communities that we're serving. So I'm going to briefly share about the Diverse Elders Coalition, the history of our caregiving initiative, which ultimately led to our caregiving toolkit, Caring for Those Who Care. I'll make sure you can walk away with the toolkit at your disposal. I just dropped it in the chat, and for anyone who joins after, I'll be sure to link it in the chat as well so you have it. And at the end, I'll share a few novel findings from our research. So the Diverse Elders Coalition was founded in 2010 to ensure the unique needs and perspectives of diverse elders and caregivers would be heard when and where it mattered. So we advocate for policies and programs that improve aging in our communities. We're so lucky to be made up of 6 incredible member organizations that represent millions of older people across our country and their caregivers, including elders and caregivers of color, American Indian and Alaskan Native elders and caregivers, and lesbian, gay, bisexual, and transgender elders and caregivers. And so we understand that the health and well-being of older adults ultimately depends on the folks who are caring for them and their health and well-being as well. So in 2018, we started conducting national research to better understand the unique needs of diverse family caregivers and the diverse elders that they care for. In partnership with the Benjamin Rose Institute on Aging and with generous support from the John A. Hartford Foundation, we began holding focus groups. We held 36 focus groups in 8 different languages across 15 cities. And we had over 1,000 respondents from diverse family caregiving communities. So we were really thrilled at just the amount of voices that we could center in this. So those voices, over 1,000 diverse family caregiver voices, is what ultimately led to the creation of the toolkit that you'll learn more about today. And it's truly a resource for health, social service providers, and aging professionals to learn more about their unique needs. It doesn't specifically focus on dementia, but it's really applicable to anyone who wants to be culturally responsive and adaptive. So really across any healthcare framework in any direct service. The toolkit includes fact sheets on each diverse community, and I'm going to show you a bit about what it looks like now. So I'm going to move us down to the table of contents so you can see what this toolkit includes. So as you can see, it has fact sheets on each community, but it really includes their unique caregiver perceptions, their outcomes, the health disparities they face, and their cultural commitment to care and best practices on how you can meet their needs. So it's a great resource that I really hope that you share amongst your colleagues as well. It also includes, I'll scroll down here, national caregiving resources, important pieces for language access, and COVID-19 resources. And especially as it relates to isolation, we know for our older adults and for folks experiencing dementia, this is incredibly important. So I want to share a few findings from our research before I close it out. So we really understand that caregiving is difficult for anyone, right? But for diverse family caregivers, and after hearing from racially, ethnically, and linguistically diverse family caregivers, we really learned about these additional tasks that they have to do. And this is what we call cultural tasks. So for this purpose, cultural tasks really include things like translating health-related information into their language, overcoming language barriers when talking to healthcare or social service providers, or even navigating things like immigration procedures or naturalization procedures. And one of the novel findings from our research is that caregivers who reported some or great deal of difficulty with cultural related tasks had higher levels of isolation, health strain, and showed more signs of depression. So for example, one of the statistics is around Hispanic or Latinx caregivers. And we learned that higher levels of strain and depression ranged from 26 to 54% among these caregivers. And that included strains on work strains, relationship strains, isolation, depression, as well as physical and emotional strain. And we understand that a history of depression may present an increased risk for later developing dementia or Alzheimer's. When we surveyed Hispanic and Latinx caregivers, we learned that 30% of caregivers agree or strongly agree to increase caregiver isolation because of their role as a caregiver. And we also learned that 16% showed symptoms of depression, sometimes or often in the last 4 weeks. So this is serious. But I do want to say that diversity doesn't only refer to race and ethnicity. It also refers to things like gender identity and sexual orientation. Many diverse communities don't see themselves as caregivers really because there's limitations in the definition. In many non-English languages, there is no word for caregiver. But for LGBT caregivers in particular, it's because we often think of caregivers as being biologically related, and we know that that's not the case. Many LGBT people have become estranged from their biological families because of their LGBT identities, and instead they create what we call families of choice. And that means friends, peers, neighbors, folks in their community who they don't have a biological relation to. And oftentimes, and really most often, families of choice isn't recognized in healthcare and social service settings. And this means that LGBT caregivers truly are not getting the information, education, and supports that they need in order to provide the high quality and sustainable care for their loved one or their elder that they're taking care of. And one other aspect I want to raise, because it relates to dementia, is that somebody who loses their memory may not remember that their caregiver even identifies as LGBT. So this is a really complicated dynamic that can arise for LGBT caregivers who are caring for someone with dementia. And it's really important to be aware of that as well. So what does this all mean and why does it matter, right? Well, like Dr. Parker says, culture matters. Culture is often the reason why diverse family caregivers take care of their family member, as in many cultures, it's what's expected of you. LGBT caregivers are more likely to report feeling like they're the only person available to provide the care. Culture impacts decisions around health, as many diverse communities make decisions collectively as a family and not as an individual. And truly, if we're not centering the needs and voices of diverse communities, we're not adapting our services to meet their needs, which ultimately leaves caregivers with the burden of things like the additional cultural tasks, like I spoke of, that if we were responsive and adaptive, we could really alleviate those burdens on the front end. So I'll make sure to drop the toolkit again in the chat. But really, if you're interested in deepening your cultural understanding, it's a great tool. I'm really proud to represent Diverse Elders Coalition, and I'm proud to share this toolkit because everything that's in the toolkit comes from the over 1,000 diverse voices. So I hope that you find it useful as well. And I'm open to any of your questions at the end. So thank you so much for being here. I'm going to pass it back to Dr. Parker.
Thank you so much, Nina, for sharing the toolkit. As you were talking, I was jotting down different notes for my own research and putting this into practice. So thank you so much. I hope that those on the call as well can take some notes as well. So now I have the pleasure of presenting Dr. Ishan Williams. As mentioned, Dr. Williams is an associate professor at the University of Virginia School of Nursing. She is also the Assistant Dean of Diversity and Inclusion at the School of Nursing. Her background and PhD are in human development and family studies. She also completed a postdoctoral fellowship in the Institute on Aging at the University of North Carolina at Chapel Hill, focused on recruitment and healthcare inequities among older adults and family caregivers. Her current research focuses on quality of life among older adults with dementia and their family caregivers, chronic disease management for older adults with type 2 diabetes, and culturally appropriate community-based interventions among African American adults. Her research further concentrates on understanding the healthcare needs of older adults and their family caregivers within the social, cultural, and geographic context. She has been an active member in the Gerontological Society of America and is a fellow of FGSA. She also currently serves as the president of the Southern Gerontological Society. Dr. Williams, thanks so much for being with us today. I look forward to your presentation.
Thank you so much, Dr. Parker. And I just feel like I'm among friends here. Thank you to Nina Darby for her introduction of what she just shared with us, because I think really if we were in person having this webinar series, we would be sitting around a table sharing very similar ideas, because we all obviously have a passion for making sure that our older adults are served and served well. And that means every one, quote unquote, one is included in that. So I'm going to share my screen so I can move forward here. Give me a second. Let's see. Okay. I think, let me try one more thing. Okay. Are you all seeing the presentation screen there?
Yes, it looks great.
Okay, great. Just had to get a verification there. So again, thank you, Dr. Parker, for inviting me and for being open to have these conversations. This is something that I truly am passionate about and look forward to more discussion at the end. So I'll try to go through some of these slides just so that we can lay some additional foundation, but I just want to ditto everything that Nina has said before, as well as Dr. Parker. So you'll start to hear a lot of the themes that they raised already reinforced in the presentation that I'm going to provide today. Okay. There we go. So today I'm going to continue the conversation. I love that this is a conversation to really talk about the importance of culture and how it is a function of our ecological system, like where we live, what we do, how we behave in any given time, and really talking about how this cultural, being sensitive to these cultural relevant items in our lives and our environment really helps us to develop better support systems and services for diverse populations. Next, I'm going to talk a little bit more about the health disparities that exist in dementia in order to understand that culture actually influences the way we perceive, the way we know and behave to improve our human condition. And then finally, I'm going to talk a little bit more about how we can adapt the resources and supports needed to continue for those living with dementia and their family support system. For this talk, I really want to start by saying that race is viewed as a socially derived concept that takes history and politics into account, but does not conform to any anthropological, biological, or genetic criteria. Race is used in this discussion to provide a context for the life experiences of people based on their identified racial group classification, and when coupled with a discussion of culture, to provide a larger landscape for which we interpret the lives of people. So over the years in dementia research, we have found they have had a really large landscape for how to better engage with patients and caregivers. However, there's been limited efforts in how to be more inclusive in delivering these care services. So we must address, to truly transform our health and our healthcare system, we have to address health equity and health disparities across the healthcare continuum. Diverse older adults and their families should have access to culturally relevant and meaningful transitional care models and services within their community. Also, this includes having multi-level strategies and recommendations for how to do research, how we should implement practice, and how we should change policies. And those should all be based on a strengths-based or using mixed method approaches. And we'll talk a little bit more about that. But the important key here is to, and I think Nina brought this up too, is that we want to include the voice of not only the individual living with dementia, but their family or their chosen family and caregiver, their partners working with them as they live and age in place. And finally, researchers and clinicians have an important leadership role to advocate for the ethical health needs of the most vulnerable or the most underrepresented populations in our community. Most of the services right now that we have do not appear to be open for all, or that they weren't created with some of these populations in mind. And that is something I believe that we can change. So just briefly, in 2020, this is probably not surprising to many of you on the call today, the individuals over the age of 85 represented 19% of the population, elderly population. By 2050, which doesn't seem very far off, populations of color will increase to surpass the non-Hispanic white population, which has significant implications for how we meet their healthcare needs. If we don't shift, we will continue to see a rise in wider gaps in health disparities and healthcare. So I hope to stimulate continuous discourse and conversations around aging within the racial and ethnic populations using an interdisciplinary team working with other multiple disciplines across the care continuum to understand the complexity of these issues related to diverse elders. So the next few slides may be a refresher for many of you, but I think it is critical to highlight and amplify why more attention should be placed on adapting services and supports in dementia care to be more culturally relevant. Here you see African Americans are at a greater risk for developing dementia, which means it is necessary to develop a wide range of services that are related to their specific needs, and similarly among Latino groups. Both of these groups report more functional dependency than the non-Hispanic white counterparts. Therefore, these have very significant and important implications for their quality of life and their service needs. Again, for my friends from the Alzheimer's Association, they do a lot of fact sheets that give us real clear information about where the impacts fall for Alzheimer's disease and dementia. So this slide really just shows some of the risk factors that many of you may be familiar with. But what I want to point out here is that Alzheimer's disease is the 6th leading cause of death in the US. It's the 5th leading cause of death for those aged 65 and older. and for women of any age. But it is the fourth leading cause of death among African Americans. And I think that's really important to highlight. In addition to the risk factors listed on the previous slide, we can also talk about risk factors that tend to be more represented among populations that have often been marginalized in our society for a variety of reasons, be it race, ethnicity, wealth and poverty inequalities, housing inequities, and poorly managed healthcare. Here are several, just so you can make a note of what you see here that is actually modifiable and how we can intervene. Again, I want to also amplify and make sure that you all understand that in addition to the main risk factors that are for the general population, Hispanics, African Americans, and women are at higher risk for Alzheimer's. Research shows that older Hispanics are about 1.5 times more likely than older whites to develop Alzheimer's and other dementias, while older African Americans are about twice as likely to develop the disease as older whites. The reason for these differences is not well understood, but researchers do believe that higher rates of vascular disease in these groups may put them at higher risk for developing Alzheimer's disease. Yet, as research and evidence does show, they are less likely to receive a diagnosis. And we know from research, early diagnosis and treatment are key to promoting living well with Alzheimer's disease or other dementia. Other groups, and Nina identified this subgroup as well, that tend to experience disparity in cognition are LGBT older adults. Similar to other minoritized groups, LGBT older adults experience higher prevalence of chronic disease and disability, as well as poor physical and mental health status. Now, this slide may be a little difficult for you to read, so I'm just going to highlight a little bit of what I wanted to amplify here today. What this slide highlights is the compounded effects that LGBT older adults experience in health disparities. For example, approximately 30% of Latinos lack health insurance and a regular source of care. 47% of LGBT older adults have a disability, and 39% have seriously thought of suicide, and 31% report depression. You can see the overwhelming impact on their overall well-being, and you can see the barriers that exist. As such, it is critical to address disparities at the intersection of all of one's identities to ensure better health outcomes, especially among those suffering from Alzheimer's disease and other dementias. So you can see that there's not only age, you have race, you have ethnicity, and all of these other factors compounding each other in how we experience life and living with dementia. Another group that I continue to do research in is among rural dwelling adults. They account for about 20% of the US population, and again, suffer disproportionately worse health outcomes compared with the rest of the nation. Specifically with breast cancer, prostate, and colorectal cancers, as well as cerebral vascular disease and stroke, have greater prevalence and age-adjusted death rates and are diagnosed at later stages than their urban counterparts. This is incredibly important as certain barriers related to rural residents may lead to delayed detection of cognitive changes, such as fewer rural dwelling healthcare providers and limited service providers. Additionally, rural residents tend to underutilize medical and social services, particularly specialist services such as cognitive evaluations. They also face difficulties in undergoing cognitive evaluations and accessing care delivery. This leads to then lost opportunities to treat. You know, I showed the earlier slide about these modifiable factors that are actually treatable and related to mild cognitive impairment. But as the population ages, the incidence of chronic disease, as we know, including Alzheimer's disease, will rise. In rural communities, there is often a lack of mental health specialties. Therefore, most people receive care from their primary care practitioners who face significant barriers in delivering any type of systematic program of care for older adults living with dementia. We also have another segment of our population that are non-English native speakers. If a language concordant provider is not available, we need to really be sure to find a professional interpreter and make sure that there's reducing the language barrier, as Nina highlighted earlier. It's very difficult to do this, but it is also really difficult to lean on family members. And we really do want to try not to lean on family members in a medical situation, and sometimes in other social settings, to really get the services and supports that they need. Time constraints also limit the use of translators, which creates additional barriers, and individuals may just not feel empowered enough or comfortable enough to advocate for themselves. So as a result, these issues can amplify one's barriers to access any type of service or supports in dementia care. So I've talked a little bit about the importance of having culturally sensitive programs and support services, and how health disparities, I've talked about the health disparities for older adults from racial and ethnic populations, the need for understanding other subgroup populations that have unique cultural needs, like those from the LGBTQ communities, rural communities, and non-English speakers. Next, I'd like to spend some time on cultural adaptations based on a strengths-based approach, understanding power differential and cultural norms, the importance of culture shaping preferences, and highlight how culture is used in communication. So as I mentioned earlier, or I think Dr. Parker mentioned in my bio, I do a lot of work with older rural adults and African-American communities, which require me to have a lot of creativity and genuineness in serving this community. Thankfully, I am part of that community I identify as a Black person. And one of the things that I learned early on in my research is my participants would say, why do people keep calling us a vulnerable group? Like, we're not at risk. Like, why are we always seen as a deficit? And so it really helped me to start to change the frame of how I approach populations, especially within African-American and Black populations. It often wasn't that they were hard to reach. Often researchers or supports just were not taken to that community, or they weren't asked to be a part of certain programs or development of interventions. Like, their voices were noticeably missing. And so many of my participants would acknowledge that they didn't feel like this was something that was for them. And that was really powerful for me. And it really stuck to me to help me to continue to frame things in a way that was more inclusive, so that I did have the voice of patients, of caregivers, and maybe other family members that may not be necessarily identified as a caregiver, but have a lot of connection and support for that family. And I have here next about social support or social networks. Within my research, these are networks that provide the greatest amount of care and support that is unpaid, and they're different. These units some are very vast and wide, and some are very diverse but small. So we have to think about how these social networks also create a culture around the care for which the older adult is living. And then I have, culture, the African-American or Afrocentric culture that I've often used in my research really focuses on a collective-centered approach, often seeking help from family and friends, or, like as Nina suggested, defining what a family is. But this type of care reflects a high level of cultural reasoning and meaning, which then influences behavior. And research evidence does show, however, that family caregivers from minority groups such as African Americans tend to provide more care than their white counterparts, even after adjusting for the health risk. And in my research, I believe that such considerations of looking at a social cultural framework while simultaneously respecting individuality is critical. I believe that this consideration is fundamental to providing effective healthcare to all patients, irrespective of their race, their ethnicity, gender, religion, class, sexual orientation, geographic location, or other cultural categories. So I talked a little bit about family dynamics, but here I just wanted to point out that, I don't think that this is a surprise. Each family is unique and each family has its own set of dynamics, which does impact the development of ideas and the ways of behaving, as well as how people interact within that family. Resilient families are able to increase agency by gaining a sense of coherence, maintaining their hope, and focusing on growth and forging a group identity that includes but goes beyond the actual condition that they're living with, like dementia. Also, family systems have a shared belief system that shapes how they adapt to stress and change. They make meanings out of their challenges that they face. What seems overwhelming and difficult for one family member may be embraced as a valuable difference in another. And then healthcare professionals, I believe, should attend to this meaning and value families assigned to any difference or disability. So these ideas, even on this slide, should really highlight and show to folks, this is really person-centered care. This is what we mean by actually asking the patient or the individual how they feel like how they define their illness, what they make sense, how they make sense of what they need. In order to help people live with dementia and Alzheimer's disease. I went back, sorry. Resilient families. So let's talk a little bit about, I think, the clarity and collaborative problem solving are key elements of healthy communication. There needs to be direct messages delivered in open and collaborative environment, which results in increased communication. But sharing the care among family members often requires frequent information exchange, decision-making, and cooperation. But not all families can do that. So they may need help from service providers or health professionals to really understand how to best communicate across these, even within cultural groups. And also highlighting spiritual or religious beliefs and practices. I just want to, highlight that we just can't ignore that there are within group differences as well, due to the individual cultural frames that people can simultaneously be a part of a cultural group and hold beliefs that are not shared by some of the members in that group. And I think that's really important. Also, key issues to remember. It's important to understand how cultural norms and values, as well as structural barriers within a society, help shape the ties that exist within this population. Evidence suggests that there may be social historical explanations for how the formation of these interdependence on family and community members and the expected reciprocity between family members, unlike what we've seen in non-Hispanic white families. People, no matter what, want to be valued, no matter what race, ethnicity. And in my research, engaging with rural and African-American participants, it really dictated my need to invest into the community, do outreach, have honest and respectful communication, have the time to consider the different options if it was brought to me by participants whom I was hoping to serve. And I had to be willing to go back into that community and share like things that they needed versus what I wanted to get from them. So making sure that I was able to disseminate and get things and resources back to the community and not only ask for them to give me the help that I needed in my work. So again, people want to be valued, people want to be respected, and people want honest communication. I did want to highlight here, again, I keep missing this point about health literacy. That is really important, working with families in Alzheimer's disease or dementia. These are really difficult conditions to explain, and there's just little education and awareness within some of our diverse communities around this, around the area of Alzheimer's disease and dementia. So I really do feel like there's a need to continue to do more education in these different cultural groups. So understanding through a strengths approach. The client here, as I've mentioned earlier, is that they are involved, the client or the patient, they're involved in how they define success. What is success for them? What is their priority? And again, we want to create a safe space for this shared reflexivity. Improvement of activities, which frequently draw upon like problem-focused approaches, that those imply blame or someone's at fault. So such approaches can serve to close down the conversation or the discussion, and it even raises anxiety and inhibits any type of improvements that you are seeking. In contrast, a strengths-based approach focuses on how to serve and create a safe space where shared practices rather than individuals are the center of attention. Strength-based policy practice is more than mere solicitation of ideas. However, its utilization demands that the client or the patient be involved throughout the policy development, the implementation, and even how you assess whether or not it's going well. This process promotes hope and a positive perception of the environment that they were welcomed into. It has the potential to profoundly shape the product of the outcomes of the services and the supports that you're trying to develop. So we want to advocate that we can also empower our patients and our clients to meet their needs and goals because they're then involved from the beginning. So here I just put a couple of my projects that I've used to culturally tailor some of the interventions that I've used. The first here is the taking care of sugar. It was developed this is a diabetes intervention developed among rural African Americans using Afrocentric cultural norms and principles of adult learning in a group setting. We used storytelling, and our participants told us that they received better education if it was similar to like a Bible study. And so we tailored this intervention that we had tested in a small group really to fit African Americans who were suffering at a disproportionate rate in this rural community. The Family Quality of Life instrument, my colleague Dr. Rose and I developed this to really identify what resources and services people living with dementia, as well as their caregivers, found as being really important. This was something that we developed to use in a clinical setting so that when families were engaging with a practitioner in a healthcare setting or even a social setting, they were able to provide actual factors that they felt like were really important to them. And in developing this tool, I say culturally tailored because we really sought after getting individuals who lived with the disease, as well as care partners from a variety of family descriptions, like in terms of whether they were identified caregiver or were multiple family members, were able to give us some input into how to develop this tool. And I think that that was really critical to developing a very useful tool. Also, community advisory boards. I put this at the bottom because for my work, this is something that I've used throughout a lot of my projects, simply because it provides me with a check of, is this what the community that I'm most focused on interested in? Am I addressing their cultural needs as well as their individual needs? How can I tailor it or change it to really make sure that I'm meeting those needs? And so it allows me in that group, they often tell me how to change the wording, how to rephrase questions, how to change my flyers, how to not to present things in non-judgmental ways, because sometimes we as researchers forget how we ask people for things. And so I think that having a community advisory board that is, again, inclusive of voices that come from not only professionals, they are important, but also including them with individuals and care partners and caregivers. Culture, as I've said before, may affect many aspects of the caregiving experience, such as coping styles and social support. And so we respond to these cultural factors by adjusting our methods, our processes, and even the interpretations to explain the nuances in the human condition. This requires the ongoing practice of respecting the knowledge gained from personal experience that they share, the wisdom handed down through generations, and a way of viewing the world through their traditional ways, their values, and their roles. So this is not coming all up at once, so let me pull some of this. Okay. So now we should think about how culture intersects with health and how we understand the lived experience of older adults and their families. Here I've just listed, taking some notes from my mentor, Dr. Whitfield, where he talks about these different cultural models. One is a cultural deviance model, as you can infer, that model typically looks at differences or deviations or deficits between groups as an inferior, like it's a negative. The cultural equivalence model, many of you may be aware that this is a model used often to reduce cultural bias. Think about measurement tools, like I was discussing the family quality of life tool, ways in which you can minimize how questions are asked or words or how you measure certain things, because different cultural groups may not identify with that term or may not say those terms in their culture. And so having some equivalence around adapting tools to really meet those different cultural needs is really important. But what I have here is that you can't ignore that some of that will be contingent upon education, socioeconomic status, even within groups that may share some of the similar cultural frames. And then finally, a model that I believe is most used in my research and others around cultural responsive research is this cultural variant model, where you look to embrace a perspective that seeks to understand the role of and the meanings attached to culture in individual, family, and community development while discouraging a deficit framework. And so again, I think the strength of this is that you're able to understand a variety of how cultural contexts are used to, and what that means for people as they live out and live with a particular disease like dementia. But there are also, weaknesses. It's hard to measure culture. I know Peggy Dilworth Anderson developed a cultural justification scale, one of my mentors, and I believe that that's one of the things that we've been pushing in research is to try to have additional ways to measure something that is, as we know, culture is very inherent and woven into our human fabric. And so sometimes it's really difficult to identify how to tease that out from what we're seeing. So why is this significant? Historically, being stigmatized or oppressed results in poorly managed care and transitions, poor health outcomes, and increased healthcare costs. And trust and communication between not only the team members, but the individuals and the families really pushes forward the empowerment structure and culturally tailored coaching. And these adaptations really make care and transition smoother for adults living with dementia. With a strong commitment to culturally sensitive care, providers deliver better diagnoses and outcomes for patients with AD or other dementias, and support services can become more inclusive such that optimal healthcare is for everyone. And here, what I've done is I've listed a few ways in which we can do this. Like, I think these are easy and adaptable approaches to understand individual and patient's background, their ethnicity, their belief system, use of a patient's language, interpreters. I can't emphasize enough, building trust and relationships encourages a shared understanding. And of course, being supportive of the patient's sexual identity, gender identity, and sexual orientation to enhance the interactions. Any intervention needs to be adapted to each cultural community, acknowledging the within group differences and subpopulations that also exist. Let me keep going here. These next couple of slides, I'm gonna try to summarize because I really wanted to make sure we had time for questions. So I've talked a little bit about health disparities and culture and how more education is needed on what dementia and Alzheimer's disease is among all populations, but especially among groups that have been consistently underserved in healthcare settings. The overall goal here is to provide environments where people feel that they receive effective equitable, understandable, and respectful quality of care and services that are really responsive to their diverse healthcare needs and cultural health beliefs. Strategies for mitigating, because I always feel like I come to these webinars and people don't tell me like, what can we do? I definitely am an educator, so I always support education and training of healthcare providers, community leaders, and even our organizations and support services that engage with people across the spectrum, because this is the only way to build relationships. We need to be more genuine and authentic as we can, explore ways and how to integrate the caregiver into the treatment plan, because we know that they have a significant impact for caring for someone with dementia. We also need to be present and visible in the community. This helps to bridge relationships. And finally, engage in partnerships and communities with people with dementia and their families. So this is just 4 phases to end out. I've already talked about these ideas in terms of making sure that the caregiver and the older adult with dementia is at the table for understanding what information you need to share with others, how they can be very important to helping you change wording, names, resources, and caregiving scenarios that you may even use to deliver your services to make sure that they're suitable for the cultural context. It's also the preliminary test of resources with the population is critical to include the voices of both, I've said that, both patient and caregiver. And then when inclusion of culture and people who are directly impacted by the services or program, the evidence is clear that there will be benefits and more acceptability. We need explicit application of these inclusive practices where it is inherent in every developed policy, program, and service, respect for culture and their traditions, and adaptive behaviors of a group. Research and services aimed at doing this really will remove obstacles to wellness, to health promotion, and overall health by unique, holistic perspectives. And I'm done. Yay. I didn't leave much time, but I'm gonna go back and
thank you so much. I don't want to say you're done because it's so many more things I have questions for, and I know that you could talk about. So thank you so much to you and Nina for your talks today. I'm just going to go in the chat and I'll probably get to about 2, hopefully maybe 3 questions. So we have a question. Is the Family Quality of Life instrument available to the public? And if so, can you provide a citation?
I can provide a citation, and when I send the PDF of these slides, I'll make sure to include it. It is available to the public, but again, it was intended to be used in a clinical setting. So I've given it to family members and say, just take it and then show this to your provider and see if that can at least start a conversation for some of the supports that may be needed for each family.
Thank you for that. And then also another question is, what commitment do you ask of your community advisory board for your ad hoc meetings or your monthly meetings? That would be helpful.
So that's a loaded question. So the short answer is it depends. It depends on the scope of what I've asked them to do for that particular. So I have one community advisory board now, but I've had like sub community advisory groups for different projects and for different reasons. But I am a firm believer of my community members are researchers, or not researchers. I don't necessarily think they even want to be called that, but they're really an integral part of my team. And so I pay them for their time. And so up front, we have a contract or what do we say, a shared governance type of agreement, which says what they're being asked to contribute, and then what I'm willing also, or my team, I can't say it's just me, it's a team of people who would be willing to come and do other things for the community. It may or may not be related to dementia, but that is a commitment that we've made to our community advisory board, because they're giving us their time, their ideas, they're reviewing protocols. I mean, it's pretty in depth. And so I really do believe in making sure that they are compensated as well as not just financially, but with our time as well into their community goals.
Yeah, thank you, thank you, thank you. And I saw this question and it made me jot down notes to the question. So I'm interested in your response. There was a question, do we know if there is a correlation between generational trauma and the likelihood of developing dementia? If so, what might caregivers do to mitigate the effects of generational trauma on their own health? That was a loaded question and I was excited. I was like, oh, this is another research study. Let me write it down. So I don't know if you have an answer to that one.
Oh my, that's a really interesting question. I'm not sure that I've actually ever had that question, but I'll talk about it from a perspective of, we know that racial trauma exists. We know that the way we adapt to that trauma, or the way stories are passed down generationally about trauma, it has to have some impact, but I don't know if there's a correlation. There may even be someone on the, in our group here that may know that answer. So please let us know and send Dr. Parker an email after. But that is a really interesting point to consider, because I do believe that there definitely are generational passed down generational trauma that I think over the years has some, I know we know that there's some biophysiological impacts of how that how we address stress and how we cope. All of those things are related. So, but how it connects to dementia, I can't say that I've really read anything about.
So with the permission of Aisha, I hope I'm saying your name correctly. I'm going to write that down, and potentially you might see it in publication in a couple of years, so we can. That's a phenomenal question. So at this time, I just want to say thank you to everyone for joining us today. I also want to thank Nina and Dr. Williams for sharing your wisdom and expertise. Thank you, Jason, for the phenomenal live tweeting that you did. We hope that you will join us for the upcoming presentations that will provide examples of how cultural adaptations are provided to specific racial and ethnic groups. Please be on the lookout for our future talks. Also, keep the conversation alive on Twitter using hashtag Culture Matters in Dementia. Have a restorative and restful weekend. Thank you.
Thank you.